Yes? Good. So good morning again, and let's continue with our session. We are going to be discussing now about systematic reviews, methodology, and lessons learned. This will be a critical aspect of our review of the evidence for electronic cigarettes. So first we have with us Dr. Jon Samet. He will be doing the seminar, the presentation through the web. And Dr. Samet is a pulmonary physician and epidemiologist. He's a professor and chair of the Department of Preventive Medicine at the Keck School of Medicine at the University of Southern California. And he's also the director of the USC Institute for Global Health. His research has focused on the health risk of inhaled pollutants, particles and ozone in outdoor air and indoor pollutants, also including secondhand smoke and radon. He has also investigated the occurrence and causes of cancer and respiratory diseases, emphasizing the risk of active and passive smoking. And he also has a lot of experience in the topic of systematic reviews, and he has led several important National Academy of Science committees that have discussed at great length the importance of systematic reviews when evaluating environmental toxicants. So I think, are we ready to go? Do we have Dr. Samet? Yes.
Hello?
Hi, John. Can you hear us? Are you there, John?
I'm here. Can you hear me?
Yes, we can hear you very well. We just, I don't know if you heard the introduction. We just introduced you, and we are ready for you.
I did on it. Yeah, let's see. And actually, is what I don't see is the slides up, or at least I'm on the regular website.
The slides are on. Yes, we can see the first slide.
Okay, all right. For some reason I'm not, but okay, I'll just go ahead without. So I've got them right in front of me. So thanks, and sorry I can't be with you. I saw a lot of familiar faces and names. So if we can go to the second slide, in my brief time, I'm going to go over about 50 or 60 years of thinking about evidence and start with the processes used in the Surgeon General's reports, and then move on in those reports to systematic review and secondhand smoke and our looks at strength of evidence. For those not familiar with the International Agency for Research, or IARC, paradigm, I will mention that as another approach for integrating multiple lines of evidence. And then I'll move on to some more recent activities with the IRIS program and a recent report I led on using 21st century science, primarily omics and risk assessment. So if we can go on to the third slide, I'm going to move on and talk about the Surgeon General's reports. The fourth slide, which you should be on now, shows the original 1964 report and the 2014 report 50 years later. You might notice the difference in size, 330 pages on the right and about 1,500 on the left, not counting web supplements. The 64 report is groundbreaking in its methods, and I think it's worth spending just a moment on that report. So if we could move to the fifth slide, which has some animation in it, and just quickly run through the animation, you will see Luther Terry holding the report, the committee that put the report together, and the staff who did the report. And I think important to note there are an awful lot of people there, and this report indeed was a true systematic review that involved a large team to carry it out. So if we can go to the next slide, this slide describes the methods of the report. And again, a few things just to highlight. There was a plan. It was clear. The committee that did the report set out to identify all relevant evidence and to examine the validity of individual papers to look at what the authors said and to reach their own conclusions. Importantly, as part of the report, they proposed what they call criteria for causal inference. You remember it was about the same time, in fact, 1965, that Sir Austin Bradford Hill published his widely cited paper with his guidelines for causal inference. So if we can go to the next slide, here are those criteria. Consistency association among epidemiological studies primarily, strength, specificity, temporal relationship, cause before effect, and then the coherence of the association. And this is where the integration of multiple lines of evidence figured in. And again, importantly, this was where expert judgment was used. If you can go to the next slide, which shows the rats and lab coats and the smoking people, at the time there was a great deal of contention about mechanisms, biological plausibility of a causal association between smoking and lung cancer. And this report, if you were to go through it, carefully considered what was in tobacco smoke, the animal data that were available at the time, and mechanistic information, again, of course, viewed with the lens at the time. So the causal criteria through coherence and strength of association, for example, lent themselves as a way to think about evidence integration. If we go to the next slide, this is a table from the report that describes the findings of the cohort studies that were available at the time. It actually represents a pooled analysis. You can see the observed deaths, the expected deaths, and the mortality ratio, this being for all-cause mortality, and an approximately overall increase of 1.7 down at the bottom right. Interestingly, if we can go to the next slide, this was put into a more contemporary context in a letter to the editor published in the New England Journal in January 2014, 50 years later, putting the data into the form of a forest plot and a summary estimate. The point here is that these reports began with a tradition of looking at and summarizing the evidence available on a particular cause, a particular outcome that was examined in relationship to smoking. If we can go to the next slide, this comes from the 2004 Surgeon General's report, for which I was the senior scientific editor. And in this report, we went back to re-examine how evidence had been looked at in the report and address some issues that had come up with drift in terminology, particularly for describing the strength of evidence. And in this report, we proposed a four-level classification for describing the strength of evidence. Again, in relationship to your activities, the point is to think about a uniform way as you look at different outcomes to describe the strength of evidence. Next slide, please. So this is Surgeon General Koop, and again, there's some automation here of the 1986 Surgeon General's report, the first to address involuntary smoking. If we can go through the automation, the slide, the plot shows the available epidemiological data at the time on passive smoking and lung cancer. And then, of course, there was this first conclusion: involuntary smoking is a cause of disease, including lung cancer in healthy non-smokers. And again, if you go and look at the logic in the report, you'll find that it was based on integration. It was based on understanding of active smoking and lung cancer, the epidemiological information on passive smoking and lung cancer, and then quite a bit of attention to the comparative composition of mainstream smoke and secondhand smoke. Again, the text written in the form of expert evaluation of the evidence, but the decision was based not only on the 7 or 8 epidemiological studies available at the time, which primarily gave an indication of magnitude of risk, but also on the sort of much wider knowledge about mainstream smoke, secondhand smoke, and active smoking. The next slide is from the 2014 report, and this slide gets at the further continued use of meta-analysis. In this report, we examined the evidence for secondhand smoke and risk for stroke. In the reports, mostly for outcomes for which a causal conclusion has not been reached, we have been doing systematic reviews and meta-analyses as appropriate. This report, again, based not only on the epidemiological information, but on a great deal of information about potential mechanisms, reached the conclusion that secondhand smoke was a cause of stroke, really, so in a sense, amplifying the earlier conclusion that secondhand smoke was contributed causally to ischemic heart disease. So the next slide goes back to the 2006 Surgeon General's report, which comprehensively covered secondhand smoke, and in that report there are a variety of systematic reviews that let's see, I'm sorry, I'm on the lagged here. So in that there are a number of systematic reviews that were included. So let's see, if we are in sync, we should be at the IARC slides now. Is that correct? Yep, okay. So for those of you not familiar with the International Agency for Research on Cancer, it of course does reviews of the carcinogenicity of a wide range of compounds, agents, and exposures. And again, I put up 2 of the recent reports just as examples, working groups that I led, monograph 83, volume 83 on voluntary and active smoking and passive smoking, and then the outdoor air pollution monograph 109. If we can go to the next slide, probably some of you in the room have been involved in the IARC approach, but, and again, just run through the animation here, but the evidence is brought together from humans, experimental animals, and then mechanistic data, and there's an overall evaluation given to the agent based on these different lines of evidence, with group 1 being the highest level of classification, carcinogenic to humans, and you can see the additional gradations that are given there. We can go to the next slide, and again, this is probably familiar to many of you. This is the IARC classification, and you can see the table that cross-tabulates the findings in humans and in experimental animals. Now, what is not shown here is how mechanistic information can be used actually to advance the classification if there is a reasonably certain understanding of mechanism. So again, all lines of information are considered in the IARC classification scheme. Now, if we can move on the next slide, which should be the 2 reports from the National Research Council, one having to do with formaldehyde and specifically, and the other with the Environmental Protection Agency's Integrated Risk Information System, or IRIS program. the two are sitting there because I chaired the committee that reviewed EPA's IRIS assessment of formaldehyde. We looked at a quite massive document that the agency had put together on formaldehyde. It considered a number of effects, including cancer and non-cancer effects. The report ended with a discussion of the IRIS process itself and suggested there was a need for revision to incorporate more contemporary processes, including systematic review and potentially meta-analysis. The agency moved on to, and still is, revising their processes, and I then chaired a committee to take a look at the revisions. So if we can go to the next slide, this is the one labeled IRIS Process A Framework. Here we charted out how the agency could go, and essentially does go, from a consideration of a problem and a scoping at the start of the diagram, in the end to fulfilling what the IRIS program is supposed to do, which is to provide an assessment of whether a hazard exists, and then, if so, to understand dose response and to provide some numbers about risk according to a process the agency uses. If you trace along the boxes, you'll see that there's a scoping, a broad literature search, there's the development of protocols for systematic reviews, and again, importantly, the systematic reviews are multiple. They relate to human, animal, and mechanistic data. So it's a complex, potentially a complex process to carry out depending on the wealth of information available. So the process involves formulating the specific questions to be answered for the systematic reviews, gathering up and evaluating the relevant evidence potentially coming from different research disciplines, and then moving on to the next slide, you can see that here I've highlighted the fact that the evaluation of the studies involves using systematic review approaches in the IRIS program. And then if we can move to the next slide, you'll see again here I've highlighted the integration of evidence now from human and animal and mechanistic research. So here, there's been a great deal of discussion for years about how to do this task. I've been on committees over the decades that have discussed the potential, for example, for Bayesian approaches to provide useful ways for such integration. At the moment, we still largely rely on expert judgment for this purpose, but what this diagram shows with regard to the IRIS process, and again, I think relevant to your task, is the conduct of targeted systematic reviews addressing specific questions, but reflecting the lines of evidence available, including from human, animal, and mechanistic research. So moving on now, we should be up to using 21st century science. I'm going to quickly draw your attention to this report, which was released in early January. This was sort of the next in a series of reports from the National Academies on risk assessment. If I could have the next slide. This report grew from two prior reports, one on toxicity testing in the 21st century, published in 2007, and a later report on exposure science in the 21st century. And again, I know that many of you are familiar with these reports. I think they provide useful background for considering exposure and also how we are moving to assess toxicity through use of test systems in which we examine perturbation of pathways thought to be associated with injury. So the next slide, which is called the new direction for risk assessment, comes from the report. Our charge was to look at how pathway, these assays, looking at pathway activation could be used in risk assessment processes. And if we can move on to the next slide, questions to address. This describes the committee's specification of issues that will inevitably rise in using pathway approaches. These, in the end, will involve integration of evidence from multiple lines of assessment, ranging from these new in vitro high-throughput approaches to conventional animal bioassays and to epidemiological data when available. We go over how biomarkers can supply the linkages across these different areas. So this should be my last slide with a few bottom lines on some tough issues that you'll face. So the first bullet, obvious but I think often forgotten, is to specify what questions you want to address as sharply as possible. I think when systematic reviews fail, it's because people have not done the hard work to decide what exactly they want to address in gathering evidence. You know, of course, systematic review with or without meta-analysis is time-consuming. It has the advantage of being done right, of being transparent. If you decide that you will not undertake systematic review on particular points, you know, I just urge you to think about what are the transparent replacements. You know, again, I think at this point in the evolution of thoughts about evidence integration around hazard and dose response, we're largely still reliant on expert judgment. And again, if this is the approach you take, then I think it's important to be very clear about sort of what the rules are, the principles are that will guide the committee's judgments. And then last but not least, and again, there are many models of how to do this, to describe strength of evidence uniformly. So I'll end here, and again, sorry I can't be with you, but I guess I'll be available to answer questions now.
Yes, thank you. Thank you very much. We have Jon, can you wait until we finish this session, or do you want that?
Yeah, I can. I'm free for the hour. Anna.
Perfect,
so,
very good. So then we'll continue and we'll come back to the question.